Good afternoon, everyone. I'm Tomiko Brown-Nagin, Dean of the Radcliffe Institute for Advanced Study at Harvard University. I'm so pleased to welcome you to the very first installment of our virtual Radcliffe discussion series, exploring health equity in the time of COVID-19. This new series reflects three critical elements of the Institute's mission. First, it reflects Radcliffe's commitment, articulated in our strategic plan, Radcliffe Engaged, to examine and address pressing issues facing our society. Second, it reflects our conviction that drawing insights from across academic disciplines and professions allows us to advance public discourse and discern innovative solutions to complex problems. Third, and finally, this series reflects the Institute's commitment to equity and opportunity. We've seen in recent weeks that COVID-19 disproportionately affects vulnerable and marginalized communities. We have both an opportunity and a responsibility to examine the profound inequities that this crisis has revealed and exacerbated, and to chart a more equitable way forward. Today, as we begin this work, we're joined by four outstanding scholars who'll explore the important issue of health rationing protocols and the rights of persons with disabilities. These panelists are Rabia Belt, an associate professor at Stanford Law School; Rosemarie Garland-Thomson, a professor of English and bioethics at Emory University and co-director of the Emory Disability Studies Initiative, as well as an alumna of our Radcliffe Fellowship Program; Devin Stahl, assistant professor of religion at Baylor University; and Joseph Stramondo, assistant professor in the Department of Philosophy at San Diego State University. I'm so grateful to each of you for joining us. Before our program gets underway, let me also take a moment to acknowledge the members of the Radcliffe Institute Leadership Society and all our annual donors. Your generosity keeps Radcliffe programming free and open to the public, even in the midst of a global pandemic. Thank you so much for your support. And now I have the distinct pleasure of giving the virtual floor to Rosemarie Garland-Thomson.
Thank you for that really lovely introduction, Dean Brown-Nagin. I'm Rosemarie Garland-Thomson, and before I begin my brief remarks, I want to give a quick overview for the format today of our program. So there'll be 4 presentations followed by a group discussion. After that, the group will respond to questions from the audience. During the program, we encourage those of you who are watching to submit your questions at any time throughout the program. So to do it, please use the Q&A format or feature on Zoom, or you can email us at events@radcliffe.harvard.edu. All of us in this astonishing time are reading a great deal about the prospect that this pandemic crisis may force healthcare workers to make choices about how to allocate life-saving medical treatment and equipment. Public commentary and news describe this as an unprecedented situation, one that most of us have never even thought about in these past decades of abundance. Healthcare workers and systems will need to make choices that they are calling tough, agonizing, sobering, terrible choices that will subject healthcare workers to what bioethicists call moral distress. And this is indeed very true. But these tough and agonizing choices about what we now call crisis standards of care are really not new. Our nation, our institutions, and our communities have been faced with these decisions throughout our national history and, in fact, throughout all of human history. Crisis situations such as war, terrorist attacks, fires, storms, droughts, pandemics, or other natural or made-man disasters regularly upset this normal balance between supply and demand of medical treatment. Right now, the people with authority and the capacity to determine and to carry out these allocations are really drawing on precedents from history to address healthcare practice during this particular pandemic. What, however, is really unprecedented about this healthcare crisis, and what our program today is going to help us recognize and perhaps think through, is that these tough choices of allocation, or what we more chillingly call medical triage, are really about justice and equity in very, very new ways. And this program that you're tuned into today with us is going to eliminate how the historically recent concept of justice and equality is guiding medical decision-making in the 21st century and today. The perspective on justice and equality that's guiding our conversations here today could not have occurred in almost any other healthcare crisis in national or perhaps even all of human history. And let me explain that further. The four experts that the program today gathers would not have been here with you today, say before 1990. Each of us four presenters, is a bioethicist, and we are all professors and scholars at prestigious universities. And each of us is also a person who identifies as disabled, and perhaps more important, who is identified as others, including our employers, as a person with a disability. Each one of us has benefited from access to education, employment, public services that the larger human and civil rights movements of the mid-20th century have made available to a majority of Americans who were structurally excluded from full equality under the law. Civil rights laws and policies struck down barriers to equality, and they mandated access for people with disabilities, for people of color, old people, and women. This promise of increased inclusion and equality is an aspiration, of course, that is still unfulfilled, and many people do not have access to this new way of imagining and carrying out justice. Nonetheless, the very idea that medical rationing policies might discriminate against people with disabilities and other protected groups was inconceivable in national crises before the civil and human rights movements of the mid-20th century. The objections that are raised in lawsuits that have been filed by disability rights groups and organizations could not have come forward without these ideas and the policies that transformed people with disabilities from medical subjects into political subjects. That it is not just unethical, but also illegal to discriminate against people on the basis of disability has actually mobilized the entire nation to change old guidelines and to remake them to consider more equitably what justice might be. Recognizing our shared vulnerability then in this pandemic is not novel or an exception, but rather it's an opportunity to invigorate our shared national and global commitment to building together a more equitable and shared world with equality and justice for all. Now, I'd like to turn the floor over to my colleague, Rabia Belt, who's going to provide for us some legal and historical context on medical rationing and disability justice. Rabia?
Hello, everyone. Thank you so much, Rosemarie, for that sort of wonderful introduction. Thank you to the organizers, especially Amy Montilli, for all of your work to put this together. Thank you to Radcliffe and Dean Brown-Nagin for creating this virtual Radcliffe series and including people with disabilities at the forefront of it. my student Selena Malave for her research assistance, and to the disability advocates and healthcare workers who are doing the work in the field to take care of the disability community at this time. So, my name is Rabia Belt. I'm an associate professor at Stanford Law School, and I'm a legal historian that studies disability and citizenship. I am also a council member on the National Council on Disability, which is the federal agency that advises the President, Congress, and other federal agencies on disability policy and procedure. For this webinar, though, I am not speaking on behalf of the council, just for myself. And as Rosemarie said, I also identify as someone who has a disability. I have many loved ones with disabilities. This is not just an intellectual exercise. This is also a personal and lifelong mission. So I want to give a really brief background on sort of the legal framework that we're dealing with here. I want to start with two cases that are not the governing legal rules for this pandemic, but they embody legal principles that I think we have to keep in mind when we think about health inequity and disability right now. The first is Buck v. Bell, the infamous 1925 decision where the Supreme Court found that a Virginia state law that permitted compulsory sterilization of the unfit was not unconstitutional under the 14th Amendment. Sterilization was justified for the protection and health of society in general. What this indicates to us now is a lingering concern that people with disabilities will be sacrificed for the greater good on the basis of ideas about social welfare and health that don't include a intense look at ableism. It may also lead to a chilling effect where disabled people avoid healthcare either for COVID-19 or other healthcare issues out of fear that they will not receive care or will be set at the bottom tier of healthcare considerations. This can be compounded based on people's overlapping identities, such as Black disabled people may remember the legacy not only of Buck v. Bell, but also policies such as the Tuskegee syphilis study, or Native or Puerto Rican disabled people may remember mass forced sterilization efforts against Native and Puerto Rican women. Another case, on a happier note, is Olmstead v. LC, a 1999 decision where the Supreme Court found that unjustified segregation of people with disabilities is impermissible discrimination under the Americans with Disabilities Act. This case recognizes the need to incorporate people with disabilities into society and treat them as full-fledged members. So I think both of these things, a fear, sort of a concern about healthcare triage on the backs of people with disabilities, and also an integration mandate to really sort of think of disabled people fully, should, I think, sort of guide our decision-making here. So what is the law? What are the rules that govern during this pandemic? So one thing I would like to mention, sort of for follow-up and to get citations that might be useful, is Michigan law professor Sam Bagenstoss's piece, which is forthcoming in the Yale Law Reform, and it's available now online, Notes on the Law and Ethics of Disability-Based Medical Rationing. So if you Google that, then you should be able to pull up the piece. It's fairly short. We have three main pieces of litigation. The Rehabilitation Act of 1973, Section 504, bans disability-based discrimination in federal agencies and programs that receive federal money. Title II and Title III of the Americans with Disabilities Act bans disability-based discrimination by state and local government agencies and private healthcare providers, respectively. Also, I want to note that Title II of the ADA applies to disability discrimination for people in public entities such as the state prison system. Section 1557 of the Affordable Care Act, which some people call Obamacare, bans disability-based discrimination in health programs that receive federal money or are operated under a federal program or activity. The Department of Health and Human Services guidelines flowing from these laws will be discussed by subsequent panelists when we have a deeper dive into state protocols. So for all of these laws that I mentioned, with the exception of Title III of the ADA, the protection is limited to qualified people with a disability. Title III does not have a qualification requirement. Qualification should not be a significant barrier here in terms of our thinking about disabled people being considered under triage procedures and preventing disability discrimination. So disabled people can't be deemed disqualified for healthcare just based on their disability. So you can't use it as a circular workarounds. And you also can't declare someone unqualified because of their disability if they could benefit from COVID-19 treatment despite their disability. What's clear from the law is that you can't have category-based exclusions from healthcare. So you can't say, because someone has a particular condition, you can't receive COVID-19 treatment. What the law also strongly suggests is that there's a very narrow basis for using disability as a basis for rationing care. So if a person will die imminently, then yes, you can withhold care. But that determination needs to be made by the best available evidence. Or if the underlying disability will kill the person in the very near term, irrespective of the success of COVID-19 treatment, then you can also condition care, withhold care there. You can also condition care on whether a disability will impede the COVID-19 treatment. Other than that, though, medical professionals have pretty broad discretion on resource allocation. So this is really a question not just of what is illegal, but also what is unethical. So I'd like to turn it over to Dr. Devin Stahl to walk us through those ethical guidelines and protocols. Thank you.
Thank you, Professor Belt. So hello, everyone. My name is Devin Stahl, and I'm an assistant professor of ethics at Baylor University. And I'm interested in this topic both as somebody who works in bioethics and works in hospitals as a clinical ethics consultant and as somebody with a disability. I have multiple sclerosis, which is an autoimmune disease that places me at risk for having more severe complications from viruses such as COVID-19. So naturally, people with MS are worried about not getting access to critical care resources during a pandemic. So as with many clinical ethicists, I've been asked to look and advise on hospital protocols for triage of scarce resources during this pandemic. Hospitals in various regions are attempting to coordinate their protocols so that scarce resources can be distributed fairly and equally to help save as many lives as possible. In other words, if hospitals begin running low on essential life-saving treatments, such as ventilators or critical care beds, how do they decide which patients will receive them? While hospitals are scrambling to get these protocols written, they're not without precedent. In 2009, after the spread of H1N1, the Department of Health and Human Services asked the Institute of Medicine to convene a committee of experts to develop national guidance for state and local public health officials on the allocation of scarce resources during a time of disaster. So afterward, many state and public health departments crafted their own recommendations based on the IOM's report. So if you're curious about what your state recommends, you can find this information on your state's health department website. Now, in most of these triage recommendations, the general consensus is that hospitals should prioritize patients who will survive if they're given access to scarce medical treatments, such as ventilators. At the same time, hospitals cannot discriminate against categories of people when making these judgments. Just because somebody is elderly or disabled does not mean that they're less likely to survive than anyone else. And as you've likely heard, disability rights groups have been scrutinizing state recommendations to make sure that this is not happening. In conversation with clinical ethicists from around the country, there's one triage protocol that has been widely adopted, This is called the Pittsburgh Protocol, which was drafted by clinicians and ethicists at the University of Pittsburgh. Since March, this protocol is now on its third version. Updates have been made in consultation with disability rights groups. So I'm going to take you briefly through this protocol so that Dr. Stromando and I can discuss its implications for people with disabilities. So as with all protocols, the Pittsburgh Protocol provides guidance for how to distribute scarce resources if demand outstrips supply. It's worth mentioning that neither this protocol nor any protocol has been activated anywhere in the US, meaning that we're not yet having to decide which patients will receive critical care resources if they need them. This is thanks to the ingenuity of hospitals in figuring out how to get more essential supplies when they've been needed. Still, during this pandemic or the next, I think it's worth discussing how decisions are made and on what basis. So there are three parts to the Pittsburgh Protocol. First, the document outlines the need for triage teams to make resource allocation decisions and to handle appeals to those decisions made by patients or their family members. So interestingly, many protocols call for such teams because they don't want treating physicians to decide between patients who gets access to treatments. Instead, there's a team of experts who try to apply objective criteria to determine who is prioritized. This doesn't mean that there isn't some clinical judgment involved. It just means that the treating physician isn't expected to make snap judgments about which patients are most likely to survive their illness. Instead, an outside team makes those decisions based on the best evidence that they have. The document states that the point of the teams is to avoid conflicts of commitments for physicians and to minimize their moral distress. So when I talk to doctors, many will say that they don't want to act as public health officials. They want to advocate for their patients, but this is hard to do if they have to compare one patient to another and determine who will get access to certain treatments. The second step in the protocol involves the allocation of critical care resources based on saving lives and saving life years. In other words, the goal of triaging is to save as many lives as possible, as well as to prioritize saving persons who are most likely to stay alive after they leave the hospital. So how do they do this? Well, first, all patients are admitted to the intensive care unit and they're given a score based on their predicted ability to survive with critical care treatment. You come to this score using a mortality tool. Now, the Pittsburgh Protocol uses a SOFA score, or a sequential organ failure assessment, though it says that other tools could also be used. Now, the SOFA predicts mortality on the degree of dysfunction of 6 organ systems. In other words, the SOFA score predicts how likely it is that the patient will survive until discharge from the hospital, based on how well the patient's organs are faring. Next, the triage team factors in the presence of conditions that are associated with mortality in the near term. This is where the life years saved step comes in. So the team looks for diagnoses or comorbidities that suggest, based on the best evidence that they have, that the patient has less than a year or less than 5 years to live, even with treatment, and then adds additional points for those conditions. Using the score from their SOFA assessment and the additional points added for severely limited life expectancy after discharge, each patient receives a raw score of 1 to 8, or is placed into a category of 3 priority categories. Those with lower scores get priority access to critical care resources. Those who have the highest scores are less likely to receive critical care resources. Now, if there's a tie between patients, priority is given to those who are at an earlier life stage or a lower age bracket, then to frontline clinicians or others who are central in the public healthcare crisis. And if there's still a tie, a lottery system is used. The third step is the reassessment step, where triage teams determine whether the ongoing use of scarce resources on a patient is justified. In other words, when, if ever, is it ethical to take a ventilator or a critical care bed away from one patient and to give it to another? This is, of course, a very difficult decision to make. Patients who show improvement will continue to receive critical care services, but those who show substantial deterioration may not. If, in the triage team's judgment, the patient has a very low chance of survival, even with treatment, then critical care will be discontinued and the patient will be moved into comfort care only. This might happen if a patient goes into septic shock or has a massive stroke. Obviously, some amount of time will need to pass before the triage team can make this judgment. Patients are reassessed at least once a day to see what has changed, and everyone's given a trial period to get better. How long that trial time is based on characteristics of that patient's disease. But those who do not improve or are not expected to survive may have their critical care treatments reallocated to another patient who needs those resources to survive and has a higher likelihood of surviving. So those are the basics of the Pittsburgh Protocol, and I'm going to turn it over to Dr. Droste-Armando to discuss disability concerns and recommendations regarding how to ensure that protocols like this one are fair to people with disabilities.
Thank you, Devin. And thank you, everyone who organized this great series and event. I'm very pleased to be here and have such wonderful co-panelists to have this discussion with. My name is Droste-Armando, as you've already heard. I'm an assistant professor of philosophy at San Diego State. My area of specialization is bioethics, and I sort of bring that into conversation with philosophy of disability. And so this topic, of course, is very much within my wheelhouse. What I'm going to talk to you about today are some of the critiques that have come out of the disability rights movement of triage protocols, in particular the Pittsburgh Protocol, but just sort of in general triage protocols as well. There's lots of them, more than I possibly could cover in my allotted time here. And so instead of trying to have a really exhaustive discussion about all of the different critiques, what I thought I'd do is focus on what we have that is sort of the closest thing to what we might think of as a consensus document from the disability rights movement that outlines some of their concerns. And that is a document that came out in early April from the ARC and other disability rights organizations that was endorsed by nearly 100 nonprofit disability advocacy organizations, as well as some professional medical societies. And this document, just sort of give you a little bit of context around what it is and how it works. It's an interpretation of some guidance that was offered in a bulletin by the U.S. Department of Health and Human Services, Office of Civil Rights. And so the bulletin was actually released in response to a complaint that was leveraged by the ARC and Disability Rights Washington and the Autistic Self-Advocacy Network and a number of other organizations. I'm sure I'm missing some. When the state of Washington released their triage protocol, which was actually based on work that had been done earlier by the University of Washington's hospital system. And it was found to be problematic in several ways. And so there was a formal legal complaint that was leveraged by these groups with HHS Office of Civil Rights. And so in response, there was this bulletin that sort of outlined what the legal responsibilities were of states and hospital systems that were developing these triage protocols. And so the bulletin was still fairly vague. There was some room for some interpretation. And so the groups that initially developed the complaints against the state of Washington wrote up what I'm calling the consensus document, which is a interpretation of the bulletin from HHS OCR. Okay, so hopefully you were able to follow that. But the basic timeline is that there was a legal complaint targeting the triage protocol developed by the state of Washington. And then the HHS Office of Civil Rights, in response to the complaint, released a bulletin sort of saying what should be done to address discrimination in these protocols. And then there was the interpretation of this bulletin by the same groups that leveraged the original complaint. And that interpretation was then endorsed by 100 or so like-minded organizations. Okay, so let's get into the meat of this and what the actual arguments are in this consensus document. First, it starts off with some ethical principles. Now, there are sort of areas of overlap between these ethical principles, but I think they are distinct enough that it's worth mentioning each in turn. First, there is just sort of the idea that we all have equal value, whether we are disabled or not, which seems like it should be pretty obvious. But unfortunately, this is in response to things that have been included in triage protocols that seem to indicate others believe otherwise. For instance, in the state of Alabama's now withdrawn set of crisis care guidelines, it's said that people with intellectual disabilities were very unlikely to receive crisis care and were to be deprioritized. And so it is important to have equal value of disabled lives in there as sort of our starting point ethical principle. Next, equality of opportunity for access to critical care, which is something that my colleague Rabia spoke about earlier, and that Devin sort of did a good job, I think, of problematizing in her discussion of the Pittsburgh Protocol. And so it's not as straightforward as one might think to have equality of opportunity for access to critical care. And then the ability to perform activities of daily living shouldn't be relevant to whether or not someone is considered likely to survive. In other words, when you try to predict whether or not someone is going to survive treatment or the disease, and thus whether or not it's medically indicated to provide the treatment, you can't think about, well, can the person bathe themselves or can the person cook for themselves? And that's sort of just not a relevant factor. And so that's another one of the ethical principles in the documents. Next, it's false to assume that physicians are somehow immune to ableist bias and that their judgments are just sort of objective by virtue of the fact of their medical training. And then to go along with that, the idea that triage ought to be done based on sort of the assessment of an individual's medical case and sort of the facts of their bodily function, and whether or not those facts lend themselves to survival in the short term with treatment rather than stereotype or something else. And then finally, the last thing mentioned in the document as sort of one of the broad principles is that no one should lose ventilators that they use every day when they are admitted into the hospital for care. So in other words, you shouldn't take someone's everyday use ventilator and put that into the pool that's then rationed out. If that person is admitted into the hospital, they should be able to keep the ventilator that they already have. Okay, so after the discussion of the ethical principles, it goes on to do some interpretation. And so I'll try to quickly go over some of that. First, it talks about how social characteristics are irrelevant to triage decisions, and that includes disability unrelated to near-term survival is the language that's used there. And that's important to think about near-term survival as the bright line. We'll get to that in a minute in more detail. But just in general, the idea is that people should not be discriminated against according to implicit bias, trainings, and so there should be some kind of statement that begins each of these triage protocols. Implicit bias should be accounted for with trainings, and so that ought to be something that's included. And then finally, it needs to have an appeal process in order to meet these qualifications that are put forth by the document. Next, it talks about sort of the fact that individual medical assessments need to be the basis of these decisions and not anything else like stigma. And so when they talk about sort of what the criteria used would be, they use the language of, it is clear that they will not survive in the near term. And so what that it means in practice, I think, is that we don't want to be using resources in cases that will be futile. Okay. Next, there'll be no quality of life criteria that are leveraged to make these decisions. And then finally, it talks about how we don't want to equate health with prognosis. So in other words, there have been some triage guidelines that have said that, well, what we're aiming to do is not just maximize the number of people, but we want to think about the quality of life of the people that survive based on how healthy they are. And so they dressed up sort of quality of life considerations with the health status of individuals after they get out of the hospital. And so finally, the last section of the consensus document talks about reasonable accommodations and how triage protocols need to consider those. And that includes communication access, for instance, with speech boards or American Sign Language interpreters if someone's in the hospital. Next, it includes the idea that the resources or the amount of resources being used, for instance, the amount of time you spend on a ventilator can't be considered as a factor, and that you need to be given more time on the ventilator as a reasonable accommodation if you need it. And this is, I think, conceptually distinct from the question of survivability, right? There's this question of, will someone survive if they are given the opportunity to use a ventilator? And then there's this separate question of how much resources will be needed in order for that person to survive. And I think that's important to make that distinction. And then finally, another reasonable accommodation that's sort of suggested by the document has to do with visitation policies and the idea that especially people with developmental disabilities are allowed to have caregivers and perhaps family members be with them in the hospital to help with decision-making and communication of their needs and the specifics of their medical conditions. How am I on time right now?
I think it would be a good time to transition to the question and answer period because
okay.
We can continue these kinds of questions. So thank you very much, Joe.
Absolutely.
And thank you, Devin, and Rabia, of course, as well. So I have a few questions that can be presented to us as presenters. And I wanted to begin with one that, what do you think? Are there places where disability advocates might still take issue with, say, the Pittsburgh Protocol? Devin, can you start with that? And Joe, maybe follow up.
Mm-hmm.
Sure. So there's a couple worries that I think people with disabilities might still have about this protocol, although I think it is a very good protocol, maybe the best that I've seen incorporating disability concerns. So I'll start with that just to say that I think there's a lot of resonance between those guidelines that Joe just discussed and this document, but there's still points of contention. So that SOFA score I mentioned, or the sequential organ failure assessment, Some worry that people with certain kinds of disabilities might still score highly on that. And again, a high number means you're less likely to get resources. So what kinds of disabilities might be associated with high scores on your SOFA? Things like cystic fibrosis might mean that you score poorly on your respiratory function score. So that might place you at a higher level, so you might not get certain kinds of triage care, depending on how it's being distributed. A person in a persistent vegetative state, or what we're now calling unresponsive wakefulness syndrome, they might score very highly on their neurological assessment, even though they don't necessarily have any more comorbidities or any failing organ systems. They might score very highly, even though those things aren't true. So people worry about that. They also worry about the second category of saving life years, of including sort of longer term outcomes. So there is a qualification that those who are expected to live 5 years or less will get extra points added on. And the objection is that, I mean, you can just imagine, but a lot can happen to a person in 5 years. A lot of family milestones or other accomplishments can happen in 5 years of your life. Maybe less than a year makes sense, but 5 years gets into a gray zone where we're just not always the best at predicting that somebody actually is only going to live less than 5 years. So the longer term outcomes get more precarious as we're thinking about the tools and the evidence that we have to make those kinds of projections. So the comorbidities adding on points is going to upset some people. And finally, I'll say that the use of life years or brackets of age as a tiebreaker, that upsets people as well. When you poll people, most will say that they do think age should be part of a triage factor, but there are still people who think that, you know, age, like disability, doesn't necessarily predict your outcomes, and so it shouldn't be used as a category at all in these decisions.
One of the, I think, factors that is always at play in these kinds of conversations is the issue of what our colleague Joe Michael Reynolds calls common sense ableism. And common sense ableism seems to me to operate in the way we talk about all of these evaluations of quality of life expectancy, of capacity to recover and have a long and flourishing life afterward. What do you all think about how the disability rights movement and disability advocates can counter more fully this common sense ableism that tends to operate sometimes as unconscious bias in the way we imagine what it's like to live with a disability?
Yeah, so I'll take a crack at that. I mean, that's a much bigger issue than triage protocols, of course, right? Another way to frame this question of common sense ableism is the language that one of my mentors, Hilda Lindemann, uses a lot in talking about master narratives. And so there are sort of cultural master narratives that are just sort of understood implicitly within our society about how people are, what they're like, and so on, that attach to certain groups and so on. And so I think that's what we're talking about here is how do we address some of these master narratives within sort of triage protocols. And I think that's very difficult to do. One thing that is not included in the Pittsburgh Protocol that might at least do some of the work of at least highlighting these master narratives and this common sense ableism would be some kind of anti-discrimination statements that is recommended by the consensus document. And so turning back to this question of points of conflict between the two, one of the things that's lacking in the Pittsburgh Protocol is this anti-discrimination statement that at least would, I mean, it certainly wouldn't completely overcome implicit bias, but at least would put it front and center in some of these discussions. Another thing I think that is relevant as far as the differences between the two documents is that the PIT protocol, in using the SOFA score, does depart from the ARC consensus document guidelines because the SOFA score isn't just about medical futility, right? It ranks people as being more or less likely to survive, rather than just sort of saying, okay, well, you know, they aren't a futile case, and so they were going to give them equal access. And so that's sort of how I would answer both of your questions there, Rosemarie.
I think I'd also like to add to, I mean, as Joe said, that this is an issue that goes more broadly than what's happening right now with the global pandemic. But I think as people like Sean Ose-Owosu has written a piece recently in the Boston Review about COVID-19 and the politics of disposability, there are groups of people that have always had their lives treated as less valuable, and that the idea that we were in sort of a ration situation with respect to sort of resources, even before we got to sort of thinking about writing down triage protocols. I think one thing that's also been gratifying right now in terms of reminding people about the value of disabled lives are people having testimonies in social media. So people like Alice Wong or Stacey Milburn, so disability leaders who have been talking about how sort of these healthcare decisions impact them. And I think sort of putting a face to these protocols or these decisions is also really important.
To piggyback off of what you just said there, Rabia, I think your points are very, very well taken. It's almost as if the healthcare crisis that we're going through right now will bring to the foreground some of these broader issues. And so in a sort of slightly twisted way, it might actually be helpful in addressing some of these common sense ableism issues, because the triage protocols will formalize them and have people sort of force them into a corner to write them down. And so then we can sort of address them directly.
Exactly. I mean, to see sort of the chilling statements that there are certain groups of people that just should not receive care because of these documents, and then the pushback that happens and it's getting attention is perhaps the silver lining to something that is pretty scary.
Exactly.
Which only could have happened, right, because they're public. And so encouraging hospitals and encouraging state departments to publicize protocols was such a tremendous advantage for disability rights groups, because then we got to see it formalized on paper, and then you can scrutinize it. So the transparency of these documents, and good for the University of Pittsburgh for posting theirs. They're one of the few sort of hospital systems that has formally published their exact protocol. That made it so much easier for disability rights groups to go in and have conversations that are really productive. So.
Thank you. We might want to transition now to some audience questions, which I understand are important to continue our conversation. So we're going to open up the program for these audience questions and answers from our presenters. Sean O'Donnell is behind the scenes here and has been selecting and reading the questions, and he's going to moderate then this last section of our program. Thank you.
Hi, thank you, Rosemarie. I just want to say that there have been a number of comments and several themes are emerging. And one of the themes poses a challenge to the so-called rational framework of the protocols. And the question is, why don't we just switch to a lottery system when distributing critical care resources? Wouldn't that be more fair in the long run than a stratified triage system, as it would avoid the possibility of unconscious bias from seeping into the decision-making process?
I can start on that, and then maybe Joe, you want to piggyback on.
Sure.
I think one of the issues is that a lottery system might be sort of in some ways, a first come, first serve system that would prioritize people who get into the hospital first. And lots of people with disabilities and lots of other folks who are disadvantaged in our society have a harder time getting access to care to begin with. And so they might not be the first in the hospital, which would put them at a disadvantage of getting care quicker. So by actually prioritizing people once they get there, instead of just kind of coming in as they serve them, they might actually help people with disabilities get more services than they would have under just a pure lottery or a first come, first serve basis.
Yeah, I think that I'm largely in agreement with you, Devin. I think that the Pittsburgh Protocol does turn to the lottery system as sort of a tiebreaker, and I'm not sure that I'm completely against sort of turning to it as a tiebreaker. And perhaps what we want to think about is using tiebreakers like the lottery system earlier on in the process. So we're not instead of something like the Pittsburgh Protocol and SOFA and so on, but rather, not as sort of the final last resort, a tiebreaker, right? And so, for instance, you might use something like SOFA to sort of make a determination of the likelihood that someone will survive treatment and sort of look at short-term survivability as a consideration. And then once you are reasonably sure that someone has enough of a chance to survive, you might sort of take that pool and then use a lottery system as a tiebreaker amongst those folks. So that way you're not making sort of really fine-grained distinctions between individuals where it's harder for implicit bias to sneak in. But I do agree that just doing a first come, first serve or lottery system would not be a good idea because of various systemic barriers to getting to the hospital at all that disabled people, but also poor people, people of color, and these are of course not mutually exclusive groups.
Another question that is rather provocative is the pandemic the best time to be addressing health disparities and inequities? It's unfortunate that people with disabilities as well as other minorities experience barriers to healthcare, but that seems like something to address once the pandemic is over. Right now, shouldn't we be focused on survivability and long-term outcomes?
Yeah, so in some ways I'd agree that it's not the best time to be dealing with sort of anything else besides what's happening right now. At the same time, I do think there's some ways in which these protocols can address things like social inequity and health disparities. And in fact, the latest version of the Pittsburgh Protocol, that was actually the major shift in it, is talking about social inequity and its sort of justification of not using long-term mortality and morbidity as criteria was that there are certain groups of people for whom health disparities, social inequities will mean that they don't have longer term survival. And so that's why the document wants to limit it to less than a year or less than 5 years for adding those extra points. So it does try to do that a little bit. There's only so much a triage protocol can do to address health disparities, but at least it's trying to sort of note that within the document itself and giving us some criteria for that.
One of the aspects of disposability politics is that irrespective of any particular sort of type of immediate emergency, certain people's lives are weighed as less valuable than others. So this is something that is amplifying sort of a general trend and thinking really hard about the decisions that we make about people's lives can't wait when it comes to a pandemic. Also that I think sort of, especially as Joe and Devin have talked about, making these decisions sort of, and as Rosemarie talked about it too, in terms of on some idea that is objective, rational basis, that you can be inaccurate in those decisions if you aren't thinking about things such as ableism or thinking about sort of intersecting issue. So for instance, we know that the pain of sort of Black people by medical professionals is not weighed as strongly as it is for white people. So if you're going to then sort of make a pain metric, then we have to think about sort of race. The same thing is happening here. If we want to make sure that we distribute out medical care in a way that is going to be something that makes sure that everyone is all right as much as possible.
The other thing that's actually very important here is that we can think of this pandemic, depending upon how it shapes our shared human community, as having something of a eugenic effect. And by that, we would mean that who is permitted to live and die, who is selected against and who is selected for in terms of the distribution of resources, will shape the community that we live in together after this pandemic has passed, and it will sometime pass. And so I think that we would be morally foolish not to recognize that, the community that we live in and share afterward is going to be shaped by the decisions that we make now. And we want to look at that, I think, from a moral and a justice perspective, and not think we'll just take care of this when it's all over.
One thing I would say also in response to this question is that I've seen a variety of numbers, but some as low as 10 or 15% as the survival rate of people that are actually intubated with COVID-19. And so chances are, if you're using these resources, whether you're disabled and have comorbidities or not, if you get to that point, you're in big trouble. And so to some extent, it's important to talk not only about distributive justice and what's fair when it comes to allocating the resources that we need to allocate, but also recognition justice. In other words, how we recognize different people and different groups of people as moral equals within a society. And so, this isn't just about picking the right people to maximize lives saved when using an allocation system for ventilators. It's also about who we are as a society as we recognize the value of our different members and sort of the equal moral value of each person.
I also want to note that there are a number of questions about incarcerated people or people in group homes, and questions about whether the protocols actually would apply to them and what do we do in those situations and contexts.
Well, I think we need to recognize that the institutions that we think of as group homes or prisons have significant representation from groups who are understood as protected by various civil rights legislation laws. And so we need to think through the logic of civil rights legislation in terms of what kind of protections, what kinds of rights people in these situations have in reference to equality and justice, not necessarily in reference to vulnerability or health status.
I'm really glad that the attendees are asking questions about folks who are in institutional spaces, especially places like the prison. So we know from news reports that people that are in sort of congregate care, sort of concentrated sort of settings are really facing a lot of the brunt of what's happening with COVID-19 because infections are running rampant. But then also that with, say, folks who are prisoners, sort of they can't get out unless there are considered sort of judgments on releasing people, releasing children in juvenile detention facilities and adult prisons, releasing releasing prisoners so that people don't die and sort of the infection doesn't spread. They're the hardest group of folks within the disability community to get their voices heard. So they're not represented on our panel. They can't participate sort of within this webinar, but they're really important. And we know that a disproportionate number of people with disabilities are in these institutions, in sort of the mass incarceration system, are homeless as well. And then they can't even get to places like hospitals to have these care. So we are triaging on them. So for example, like we know what happened before with New York, that prisoners were making things like ventilators, but they weren't actually receiving that equipment, even if they were sick. There are legal obligations through the ADA that that there can't be discrimination against people with disabilities that are in sort of group settings such as prisons. And I think we definitely need to highlight that.
I would just piggyback one thing really quickly about what you just said at the end there, Rabia, about the ADA applying to people in different congregate settings. The groups that brought the original legal complaints against the state of Washington actually included Disability Rights Washington, which is part of the protection and advocacy system. And so if you don't know what the protection and advocacy system is within the United States, it's a federally mandated group of nonprofit law firms that have federal authority to monitor for neglect and abuse within any kind of state-run or state-funded institutional setting, including group homes, prisons, psychiatric hospitals, and so on and so forth. And so a lot of the critique that we have of these triage protocols actually are originating with groups that are trying their best to represent and protect the interests of some of these folks.
Great. I also want to point out to people that the links to the ARC document and the Pittsburgh Protocol are on our website page. They're embedded in the actual blurb for this event, for those of you who are looking to access them. I also want to then follow up with our questions about what could be the role of an advocate, a health advocate in this time. And I think many people rely on those. And so what do you think the effects they could have in this process?
Well, I think depending on how you define health advocate, you know, that was a consideration in the ARC guidelines, or the interpretation of the federal bulletin, that talked about how as an accommodation, certain people who might need a caregiver to accompany them at the hospital should be allowed to have that caregiver with them, despite very restrictive visitation policies. And so if you include caregivers as advocates, which I think perhaps we should, you know, that is sort of something that's of great concern to some of the folks working on this issue.
It's also worth noting that a lot of these protocols will have appeals processes embedded within them. So even if a decision is made against triage for a particular individual, you can appeal that. So an advocate can be that person to make an appeal. So that might be one place in which you know, you're advocating on the behalf of a patient, and hopefully, ideally, you won't have to do that because the system will work. But because implicit bias and because all these things aren't perfect, an advocate can be a person who can appeal any decision that's made.
That's a great point.
And I think it's also important to recognize that in the past, advocates for people with disabilities were often imagined as service providers, and this has expanded tremendously since the ADA has gone into effect, and that what constitutes an advocate would be people associated with a wide variety of institutions. We're examples of this right now here. We are scholars, we are bioethicists, we are advocates working within academic communities in order to advocate for disability justice. And that's only one example of the, I think, proliferation of ways that advocacy can take place that differs now from previous kinds of healthcare crises that we've had before a more fully robust carrying out of disability justice, let's say, and civil rights justice in general.
That's great. I think it leads into this other question that we have, which is a larger one, I think, in terms of how can we ensure that policymakers developing triaging policies actually listen directly to the voices of self-advocates, especially with intellectual and developmental disabilities, in thinking through the implications of their proposals?
So one way they've already been doing that is through the Office of Civil Rights, which Joe talked about. So because these state public health recommendations were published, then disability rights groups were able to review them and then make these complaints, as they were called. So as far as I know, there's been 6, and 2 of them have already been resolved. So it seems like that system is working. And then, and then it moves into the hospitals, in which you hope that these hospital systems are listening to their disability advocacy groups. It seems like the University of Pittsburgh did that. I can't speak for all hospital systems, but ideally they should be sort of, as they craft these protocols, listening to outside groups. And so encouraging them to do that. Maybe contacting the ethics committee, who is often working on these protocols, can be one way to do that.
Just to piggyback off of what you just said, Devin, regarding the complaints that were filed against the various states, in the original complaint in Washington, but also I think in a lot of the subsequent ones, there's been sort of a group of sort of national players that are making these complaints that include the ARC, but also it includes a group called Autistic Self-Advocacy Network. And so these are folks with developmental disabilities that identify as self-advocates that are sort of doing the work. And so I think what we can do to make sure that their voices are heard is that, to keep an eye out for folks that are engaging with these issues, and then try to amplify their voices and center their concerns in, as bioethicists, especially center their concerns when we talk about these issues.
I second that, because I think the people that will be put at the bottom tiers are also the folks that it could be often harder to hear their voices. So it's easier for people that are in, say, elite spaces like mine at Stanford to get access to the media than someone who is poor, someone who is in prison, someone who's from the intellectual and developmental disability community. So I think there has to be a lot of sort of passing the mic and to really sort of highlight, so who is not here at the table that needs to be heard.
Great. And then we also have some questions about medical education and training that I think kind of feed right into this discussion. There's been some reporting that doctors are making very quick decisions, need to make sort of gut decisions. So what would you recommend in terms of training for physicians and maybe even curriculum?
I think this is a very current and important question. I have been teaching a graduate seminar this semester on disability bioethics, and one of the students in the seminar is a 4th-year medical student at Emory University, where I teach. And we have been looking at the medical issues that were part of the National Council on Disability report that Rabia worked on. And one of the various topics were things like assisted suicide, medical futility, gene editing, organ donation, and how these various issues affect people with disabilities. And this fourth-year medical student announced to our class, which also has some doctors in it, that in her years of medical education, she had never, ever studied something like assisted suicide in relation to people with disabilities, never received the kind of perspective about disability justice and even people with disabilities in relation to these particular sets of medical practices. So the conclusion that we're able to draw from something like that is that medical education needs a much more robust curriculum around these ethical issues in relation to not just people with disabilities, but other protected groups, or what we call vulnerable groups. I prefer the term protected groups, or groups that are traditionally discriminated against, that we need a much more robust understanding of the larger political, social, and ethical issues that are at stake here.
Yeah, I'll just add, I came from a medical school teaching ethics and disability ethics, and I think it's getting better, but it's not quite there yet. But I think medical schools are paying more attention. They're going through, I know at Michigan State, they were going through the curriculum, looking for ableism, looking for ways to educate about disability. So there is some hope there. I think institutions, medical schools are getting better. It's also worth noting that in a lot of these protocols, the triage team is supposed to be getting bias training before they start making allocation decisions. So that's one way in which they're sort of institutionalizing this. So even physicians who've been in the practice a long time, if they're going to be on a triage team making crucial decisions, they're expected to have training in how to do that well. So another bright spot there.
That's great. And we have one final question, which I think sort of encapsulates today's program. I'm hoping in line with our Radcliffe engaged strategic plan, which is people are asking can people best address this issue themselves? How might they have some impact on the many issues we've discussed today? Do you have any final thoughts on how people can stay engaged?
I can take a crack at this one. I think that one of the things that you can do from the comfort of your own home is to make sure that in your own life you are trying to flatten the curve. This issue of discrimination in medical triage, there is no such thing as good triage. All of the systems of doing it are heartbreaking and arguably discriminatory. I don't think I've seen a single one that sort of avoids bias altogether. And so our best hope, I think, is to make sure that triage isn't ever needed, or to at least minimize how it's needed. And so what can we do? Well, we can do our best to try to push for policies that will expand the capacity of the medical system to treat people. And we can do our best to try to push for policies that will help flatten the curve, like the extension of shelter-in-place orders. So that's really what I would suggest.
I think we can also do things to sort of lift up the voices of the people that have been doing the work. They did the work before this pandemic started, and they're doing the work now. Sort of folks like, as Joe said, the Autistic Self-Advocacy Network, ASAN, the Disability Justice Culture Club with Stacey Milburn, sort of Alice Wong's Disability Visibility Project, T.L. Lewis with HERD, the ARC, the Bazelon Center for Mental Health Law, and sort of many others. And not just think of them as sort of where you're going to pass the mic, but also really sort of integrate your sense of community and sort of your own knowledge, so that then sort of our gut checks are the gut checks of people that are really sort of at the forefront of thinking about this for a long period of time. So if you're on Twitter, link to those people. When you're talking to people in your neighborhood or sort of people in your community, this is a really scary time. And I think that perhaps sometimes people respond to vulnerability in a way that sort of really try to bracket out sort of the people that may seem the most vulnerable or what have you, because that's sort of a scary thing. And then instead, it sort of really embrace that and sort of challenge the people around you that want to do things like challenge shelter-in-place protocols, that want to sort of triage resources away from people that may need them over the long term, and sort of like constantly sort of do those checks to see who's not there and sort of make them part of your beloved community.
I think there's things you can also do locally. So a lot of local organizations who are working with people with disabilities already. So thinking about the people who are at home but are struggling to get food and medicine and personal care or mental health services. I think we can all figure out how to volunteer or donate to those local organizations. I know here in Waco, there are organizations who are helping make food deliveries, calling in and checking on neighbors, and donating masks and other sort of needed products that will be needed by lots of people, but especially people with disabilities during this time. So even though we're isolated, I think there are things that we can do to reach out to our neighbors through our local organizations.
I think also, as a kind of national consciousness raising movement, we can all think about how to encourage one another to identify as people with disabilities, to come out, if you will, as people with disabilities, which of course has traditionally not been a very safe thing to do. I've been teaching, as many of us have, disability studies and culture for a long time, and the courses that I teach often begin like this. On the first day, students say something like, when they're introducing themselves, well, I've never known anyone with a disability before. There's no one in my family with a disability, and I don't have any friends with disabilities, but I thought this might be interesting to learn about. And then as the class goes on, somebody will say something like, well, yeah, I've never known anyone with a disability, but my grandmother lived with us for the last 15 years of her life, and she used a wheelchair, or she was wheelchair bound, they'll say something like that, but she wasn't disabled. Many of us, I'm sure, have had the experience of people saying to us, well, I don't think of you as disabled. And what this means is that the stereotype of what it means to be disabled is still very much with us. And for us to, all of us, as much as we can, bring forward not only our own identities, but to encourage people to identify as disabled and to use the apparatuses of access and accommodation that are available to us, perhaps without apprehension or fear, is very important work to do.
And with that, I just want to thank everyone for being here today for the discussion. I want to thank the audience as well. Thank you for tuning in on YouTube and on Zoom. And we hope you'll continue to come back to our other webinars, virtual webinars in the next coming weeks. And we wish you all to be safe and well. Thank you so much to the panelists too. It's been wonderful working with you all. Thank you.
Thank you.
Thank you.
Yeah.